Hello everyone, I hope you're all doing well. I'm gonna start this video with one of the cases that I have treated few years ago. So I had this patient who is 52 years old. He was medically fit. He was referred by his general dental practitioner for assessment and treatment of a recurrent fluctuant intraoral swelling in a mucobuccal fold in the area of the maxillary right central and lateral incisors. So the dentist had root canal treated both teeth a year ago over multiple visits, and since then the patient experienced intermittent mild pain and recurrent intraoral swelling related to these two teeth. Uh, these episodes were managed by the dentist by prescribing multiple courses of antibiotics and eventually by attempting a non-surgical root canal retreatment. Now, on examination, these teeth were not carious, but the patient gave a history of sport-related dental injury on the right side of the face as a child. So we did our clinical and radiographic examination. We did the percussion, palpation, pulp testing using a cold and electric pulp tests, and we did a probing depth of the gingival sulcus, and also we took a periapical radiograph. Um, both teeth were tender to percussion and to palpation, and obviously they were not responsive to pulp tests because they were root canal treated. The periapical radiograph showed a solitary unilocular, well-defined, round, homogeneous radiolucent area associated with the apices of the maxillary right central and lateral incisors. Now, there was also signs of external inflammatory root resorption of the lateral incisor. The root filling has been retrieved by the dentist from both teeth, and there were remnants of radio-opaque root filling material or radio-opaque intracanal medicament. So our provisional diagnosis was symptomatic apical periodontitis associated with a previously root canal treated teeth. Um, our immediate treatment plan was to carry out an orthograde root canal retreatment for both teeth under optimal conditions, in other words, under rubber dam. We did a thorough chemomechanical debridement of both canals. We used sodium hypochlorite as the main irrigant. The treatment was carried out over 2 visits, and I applied intracanal medicament in between appointments. However, on the 3rd visit, a straw-colored fluid continued to drain through the root canals. Therefore, lesion decompression was attempted for a few weeks, and we discussed this with the patient, and we informed the patient that this tooth, to treat this lesion or this swelling, we may need to perform a surgical procedure. So we placed a small incision in the labial mucosa, and we placed a hollow sterile radio-opaque drain made of surgical suction tubing. We inserted the drain into the lesion with few millimeters protruding into the labial sulcus. The flanged ends of the tube were sutured into the surrounding mucosa. The patient was instructed to irrigate through the lumen of the drain daily with chlorhexidine mouthwash. We reviewed the patient weekly. After 6 weeks, the drain was removed. We instructed the patient to continue to irrigate until complete healing. Now, 2 weeks later, soft tissue healing was nearly complete, and we started surgical endodontic procedure. I reflected a submarginal mucoperiosteal flap, and as you can see, there was a perforation of the labial cortical plate by a large soft tissue lesion. I reflected the flap, then we curated the lesion, and I stored the soft tissue in 10% formalin and send it for histological examination. I also cut 3 millimeters of the apices of both teeth. And then I prepared the root ends with ultrasonic tips. I placed a root end filling material, and then I repositioned the sutured the flap. We gave the patient post-operative instructions. We called him for a review visit. At the review appointment, we removed the sutures and I completed the root canal treatment. The histologic examination confirmed the cystic nature of the lesion. You can see the inflamed lining of the cyst. Okay? This story leads us to the topic of our presentation, which is surgical endodontic treatment. Now, surgical endodontics is an umbrella term that encompasses a variety of surgical procedures performed to remove the causative agents of periradicular pathosis and to restore the periodontium to a state of biologic and functional health. These procedures may be classified as follows: fistulative surgery, corrective surgery, and periapical surgery or episectomy. Um, our main focus will be on the endodontic or periapical surgery or the episectomy. However, we will briefly discuss the other types of endodontic surgery. Now, before we start, I just want to inform you that except for incision for drainage, the remaining endodontic surgical procedures should be referred to an endodontist who is properly trained to do or to perform such surgical procedures, because for the best interest of the patient, because otherwise if you attempt to do any of these types of surgeries, you may need you won't have the enough experience, and you will face complications. We need special equipment to carry out these procedures, so we all have to know our limits and to refer in cases where we think the patient best interest would be in referral. Now let's start with the fistulative surgical procedures, which include incision for drainage, cortical trephination, and decompression. Now, sometimes fluctuant localized soft tissue swelling will occur when periradicular inflammatory exudate exits through the medullary bone and the cortical bone, and once through the cortical plate, the exudate will spread into the surrounding soft tissues. And when this occurs, an incision should be made through the focal point of the localized swelling to relieve the pressure and to eliminate the exudate and the toxins and to stimulate healing and relieve patients' symptoms. If the swelling is intraoral and localized, the infection may be managed by surgical drainage alone. However, if the swelling is diffuse or indurated or has spread to fascial spaces, then the surgical drainage should be supplemented with the appropriate antibiotic routine or courses. Now, so the incision for drainage is indicated in cases of fluctuant localized soft tissue swelling. On the other hand, if you attempt to incise through a diffuse indurated swelling before its localization, this procedure will not be successful to relieve the patient symptoms or to reduce the size of the swelling. Um, so when this situation exists, it has been suggested that the patient be placed on appropriate antibiotic therapy and instructed to rinse with warm salt water and hold it next to the swollen area to assist in its localization. Now, the patient should be reviewed regularly, and as soon as the swelling has localized and a fluctuant area has developed, surgical drainage should be performed. Incision for drainage is carried out under local anesthesia, which should be given as a block, preferably to give more effective anesthesia and to keep away from the swollen tissues. or it can be infiltrated peripheral to the swollen tissues. If you inject directly into the swollen tissues, this will be a very painful injection, and it can cause spread of infection, and it won't provide the necessary or adequate anesthesia. The incision is made using a scalpel blade placed at the most prominent point of the fluctuant area. This will allow the greatest flow of the exudate. Most of the time, the incision alone will provide the needed drainage. However, in cases when initial drainage is limited, then a drain made of rubber dam or sterile glove is sutured in place to prevent immediate closure of the incision and to allow for further drainage. The drain is usually removed after 2 to 3 days and the root canal treatment is completed. Now, the second subcategory of fistulative surgical procedures is cortical trephination. In this surgical procedure, we intentionally perforate the alveolar cortical plate to relieve and release the accumulated periapical tissue exudate. This procedure is usually done in cases where, in the absence of obvious intraoral or extraoral swelling, and when drainage cannot be accomplished through the root canal. For example, in the presence of posts or filling material, or in the presence of ledges, and drainage cannot be achieved through the root canal, and there is no swelling to achieve drainage through soft tissues, then our only option will be cortical trephination. The purpose of this procedure is to aid release of the inflammatory exudate through the perforation of the cortical plate. Now, patients with severe periapical pain of endodontic origin without swelling may benefit from this procedure. In cases of acute apical abscess, for example. The procedure involves the use of trephine burrs to drill through the cortical plate, and therefore there is always a risk of damaging roots and vital structures such as the maxillary sinuses or the mental nerve. Now, the last subcategory of fistulative surgical procedures is decompression or marsupialization. We've talked about this before when we discussed the clinical case at the start of the presentation. This procedure involves the surgical exteriorization of a large periapical lesion in order to facilitate healing of the lesion. The lesion is penetrated through the periosteum and cortical plate, and the patency of the opening is maintained by inserting a flanged cannula, allowing for daily irrigation of the lesion by the patient. Now, the advantage of this procedure includes reduction in the size of the lesion and therefore reduction in the risk of damaging adjacent vital structures or anatomical structures when doing a surgery. Now, let's talk briefly about corrective surgical procedures. These surgical procedures involve the correction of defects in the body of the root, or the coronal and middle thirds of the root, not the apical third. Corrective surgical procedures may be necessary as a result of procedural accidents such as perforations, resorption, root caries or root fractures, and periodontal diseases. In this slide, in radiograph A, it shows a resorptive defect on the distal side of the cervical third of the root of the maxillary left central incisor. Now, the defect was surgically repaired after reflection of a flap to expose the resorptive defect. The resorptive tissue was curated and the root was repaired with MTA. Radiograph B was taken post-operatively. Now, corrective surgery may be necessary as part of periodontal treatment also. It may involve root resection or amputation of an entire root, which entails the removal of a diseased or weak root from the multi-rooted tooth, leaving the clinical crown intact, or hemisection, which entails the separation of a multi-rooted tooth and the removal of a root and the associated portion of the clinical crown, or bicuspidization, which is a surgical procedure performed on a mandibular molar for the separation of the mesial and distal roots with their respective crown portions. This separation eliminates the existence of a forcation and facilitates effective oral hygiene practice. So for example, in cases where there is a perforation in the forcation area, or if there is a forcation invasion, we recommend bicuspidization. So we separate separate the tooth into two halves. Each half will be kept in place and crowned as an individual tooth, so the patient will be able to clean in between effectively. Now, the last subcategory of corrective surgical procedures is intentional replantation. Now, this procedure involves intentional atraumatic extraction of a tooth and performing a periapical surgery on it. In other words, we do root end resection, we prepare the ends of the root, and we fill it with the appropriate root end filling material, and then we reinsert the extracted tooth into its alveolus. Uh, this is indicated when non-surgical root canal treatment is not possible or has not been successful, and when surgical endodontics, when the tooth is in its place, is not advisable. For example, if you're planning to carry out root end surgery on a lower molar, which is in proximity to the ID canal, or a mandibular second premolar, which is very close to the mental foramen, and you expect damage to these vital structures, then you can extract the tooth, carry out the procedure outside of the mouth, and then insert it into its alveolus again. Now, our main focus in this video and the next video will be the periapical surgery or root end surgery or episectomy. Now, although non-surgical endodontic treatment is a highly predictable option in most cases, surgery may be indicated for teeth with persistent periradicular pathosis that have not responded to non-surgical approaches. Now, there are few indications for periapical surgery, and these include anatomical complications. For example, if there is a canal that is blocked, or there is a root that has a severe curvature that can prevent adequate cleaning and shaping and obturation, then we do a non-surgical root canal treatment in the accessible part of the root, and we then remove the uninstrumented or unfilled portion of the root. Now, another indication for preapical surgery is to overcome procedural accidents in the apical part of the root, like ledges that cannot be negotiated, or perforations or gross overfillings that cause persistent symptoms. So, for example, if you look at this mandibular molar tooth, you can see a perforation in the apical part of the mesial root that cannot be repaired without doing a surgery. So we do a non-surgical root canal treatment for the accessible part of the root, and then we remove the uninstrumented, inaccessible part of the root. In the second radiograph, you obviously see an overfilling of the mandibular second premolar. If we attempt to do a non-surgical retreatment, we won't be able to remove this piece of root filling outside of the root apex. So obviously we need a surgical procedure to remove it. If you look at this maxillary first molar, you can see a ledge and in the mesiobuccal root that cannot be negotiated. Then the decision was made to instrument the accessible part of the root and to resect the inaccessible part of the root. There's another example. I had this patient with persistent sinus tract in the maxillary right lateral incisor. We took a radiograph with a gutta percha inserted inside in the sinus tract to trace it. The periapical radiograph showed that the gutta percha pointed at the apical area of the maxillary right lateral incisor. The tooth has been root canal treated, and it has also been surgically treated. An amalgam root end filling has been placed, and there obviously the treatment has not been successful. So we attempted a non-surgical retreatment under rubber dam. We placed an MTA or biodentine plug at the end of the root. The amalgam was pushed into the periapical area, and we had to do a surgery to remove it. And this is the post-operative photograph showing signs of soft tissue healing. Um, when a root canal treatment fails, orthograde retreatment is recommended for treatment of failures. However, irretrievable posts or root filling materials such as silver cones and amalgam are difficult to retrieve, or the removal would result in further damage to the root structure. In these cases, the best alternative is a surgical approach and placement of root end filling material. So if you look at this tooth that has a short metallic post with a crown with defective margins and a very short root end filling and spaces in the root canal, um, it is clear that we can do a non-surgical retreatment to correct this situation. So we did a proper root canal treatment. I placed a fiber post, and the tooth has been built up with a composite in preparation for a crown. On the other hand, if you look at this radiograph, you can see that this tooth has a very long metallic post. The post is very large. The crown looks okay. The margins are okay, and they're not defective. There is a sign of periapical disease. If we try to remove the crown and the post, it will be there is a risk of damaging the remaining tooth structure. The root may fracture, and also it will also be hard for us to match the color and shape of the adjacent crowns. So the patient may not be happy about the aesthetics. The patient was happy about this crown, and the radiograph shows that the margins are adequate. Therefore, the decision was to place a root end filling material at the end and instrument the uninstrumented part of the root. Now, although most traumatic horizontal apical root fractures heal without intervention, occasionally the apical portion of the root becomes necrotic and cannot be treated non-surgically. In these cases, the apical portion of the root should be removed and the apical seal should be placed and evaluated. One more indication for periapical surgery is to explore the root surface for cracks or fractures, or to take a biopsy to confirm the nature of the lesion histologically, because although most periapical lesions are of pulpal origin, non-pulpal lesions do exist. For example, if you have a vital tooth that has a radiolucent area that's not defined, not well defined on radiographs, and the patient gave you a history of previous malignancy or lip anesthesia or paresthesia, these are indications for a biopsy to confirm the nature of the periapical lesion. Now, there are few absolute contraindications for periapical surgery. These include inaccessibility to the surgical site because of tooth location, for example, posterior teeth in a patient with limited mouth opening or a shallow sulcus, or for example, the proximity of a tooth to the neurovascular bundles or other vital structures such as the maxillary sinuses. In such cases, a periapical surgery is contraindicated and other approaches should be considered, such as intentional replantation. Now, other situations that may contraindicate periapical surgery include very short root length. So, endodontic surgery is not advised for patients or for teeth with unfavorable crown to root ratio, or if the patient has severe periodontal disease with poor prognosis of the teeth, or if the tooth is unrestorable. Now, surgery is also contraindicated in patients with terminal illnesses, uncontrolled diabetes, severe heart disease, and for patients who are immunocompromised. Uh, Also, surgery is not indicated when a non-surgical approach would probably result in success. So, for example, if you look at this radiograph from the case we've discussed before, you can see that the root canal treatment is suboptimal. There are spaces in the canal, the root filling is extending beyond the apex of the tooth, the coronal seal is compromised. Uh, so, in cases where you think that you can modify or provide better treatment for the patient without surgery, then you have to go to the non-invasive or the least invasive treatment option, which is orthograde retreatment before carrying out surgery. Now, after diagnosing a patient and getting their consent, um, all these aspects should be discussed with the patient, the financial implications, because both surgical and non-surgical root canal treatment are valid treatment options with high predictability. And it's the patient's right to be informed about both treatment modalities, the costs, the benefits, the risks, and the prognosis of both treatment approaches to make an informed decision. Also, don't forget to discuss the impact of the surgical endodontic treatment on patients' aesthetics. Surgical endodontics can cause gingival recession, papilla loss, scarring of the soft tissues of the mouth. These outcomes are not unpredictable, and they vary between individuals depending on the soft tissue type and the healing capacity, and they can cause dissatisfaction for an aesthetically concerned patient, especially if the patient has a thin gingival biotype or has a high smile line, or if the patient has prosthetic crowns with metallic margins. Then we have to readjust or replan our surgical procedure accordingly. These effects should be discussed with the patient and before performing the surgery. Then the surgery itself is carried out under local anesthesia to provide adequate pain control, and also, and most important, and to provide hemostasis during the surgery, and to provide a clean, clear surgical field. Then we achieve surgical access through the soft and hard tissues. We reflect the flap and retract it. We do some curettage to remove the lesion. We do our root end resection. We cut the end of the root. We prepare the ends of the roots and we place root end filling material. We close the surgical site and we give the patient post-operative instructions and we follow up. In the next video, we will talk in more details about the steps and the armamentarium required to carry out a periapical surgery. Thank you for listening.